Good morning. This is my case presentation. My name is Dr. Utham Sanjayan from Fetal Hospital. This is a normal posterior fossa anatomy, looking at the cerebellar vermis, the cisterna magna, the fourth ventricle, and the downward sloping of the tentorium cerebelli is noted. Normal position of trochlear is appreciated. This is a fastigium of the posterior fossa. This is a normal cerebellar anatomy showing the lobules of the cerebellum with the primary and pre-pyramidal fissures. This is the tegmentovermian angle. Normal angle is between 0 to 18 degrees. This is a classification of cystic and non-cystic lesions. Cystic lesions include Dandy-Walker malformation, arachnoid cyst, epidermoid cyst, Blake's pouch. Non-cystic lesions are megacisterna magna, isolated inferior vermin hyperplasia, Joubert syndrome, and isolated fourth ventricle. Dandy-Walker malformation, it is seen in the first years of life. Hydrocephalus is common. It's the most common posterior fossa malformation, seen in 1 in 30,000 live births. CNS associations are cortical dysplasia, polymicrogyria, corpus callosum anomalies. Non-CNS are cleft palate, facial angiomas, cardiac anomalies, Aicardi syndrome, trisomy 1813 are seen. High mortality rate is seen. And this is a picture of a Dandy-Walker malformation, showing showing hypoplasia of vermis and cephal rotation of vermin remnants. Cystic dilatation of the fourth ventricle is seen in red thick line. Superior border of the fourth ventricle, cerebellar hemispheres, anterolateral displacement, but with the normal size and morphology. Enlarged posterior fossa with the trochlear lamboid inversion is seen in yellow line. Next comes the arachnoid, small asymptomatic, can cause mass effect. Sometimes can cause obstructive hydrocephalus. It's mostly sporadic, often associated with mucopolysaccharidosis. Treatment is surgical management if needed. This is an image of arachnoid cyst, well circumcised, circumscribed with thin walled, as shown in red arrows. Can displace adjacent structures and cause bone remodeling. Next comes the epidermoid cyst. It's a slow growing, asymptomatic in children. When larger, it can cause mass effect and leading to headache, cranial defects, seizures, and intracranial increase in intracranial pressure. Accounts to 1% of all intracranial masses, can be congenital and mostly detected in 20 to 40 years of life. Association is sporadic. Uncommon association with Curarino triad is seen. Management is surgical. This is an image of epidermoid cyst. Often heterogenic and dirty CSF look on T2 weighted images, as shown in the green arrow. Diffusion restriction can be seen, as shown in the yellow arrow. The next one is the Blake's pouch. The Blake's pouch, early onset of hydrocephalus is seen. Headache, vomiting, blurred or double vision is seen. Can be asymptomatic if CSF flow is adequate. Uh, Next, it used to be considered as a part of Dandy-Walker continuum. Not anymore, due to lack of cerebellar and fourth ventricle malformation. Surgery is the optional treatment of choice. Is the treatment of choice. Uh, Next is the Blake's pouch image. The Blake's pouch image showing smooth, thin walls, most often intraventricular hydrocephalus, tetraventricular hydrocephalus, seen in green arrows. Normal worm is seen in blue arrows. CSF density is seen as in yellow arrow. This is a pictorial description of Blake's pouch in the subarachnoid space. Next is the megacisterna magna, where there is no hydrocephalus, so seen in 1% of population. Over 50% of all cystic posterior fossa malformations. No specific treatment is seen, mostly associated with autism spectrum disorder. This image of megacisterna magna, red line shows enlarged posterior fossa, which is more than 10 to 12 mm. Next is isolated inferior vermin hypoplasia. Is seen in 10 to 19% of posterior fossa anomalies. Comparatively, it has a good prognosis. This is an image of isolated inferior vermin hypoplasia. Partial vermin hypoplasia is seen as in the red line. Normal superior portion of the vermin is seen in the green line. Next is Joubert syndrome, ataxia, dysmorphic facial features, and oculomotor apraxia, developmental delay, speech and motor deficits are seen. Um, Next, prognosis, persistent neuromotor development delay is seen with retinal dysplasia, shows poor prognosis. This is a image of Joubert syndrome, showing absence or hypoplasia of molar tooth sign. Next one, isolated fourth ventricle, increased intracranial pressure is seen, causing diplopia, ataxia, and nystagmus. Hemorrhage of obstructing exit pathway, dandy Walker malformation, cyst masses, most common congenital causes. Complication after lateral ventricle shunting, most acquired cause. Choroid plexitis, ventriculitis, and CNS tuberculosis are other associations. This is an image of isolated fourth ventricle. Enlarged fourth ventricle as seen in red lines. Transepidermal CSF seepage is seen. Posteriorly displaced, otherwise normal vermis is seen. If This is a quick first look. If the vermis is hypoplastic and if it is not rotated, it is dandy Walker malformation. If it is that is no rotate. If it is rotated, this dandy Walker malformation. If it is not rotated, isolated inferior vermin hypoplasia and Joubert syndrome can be considered. If the vermis is developed but displaced superiorly, it is Blake's pouch cyst. If it is displaced inferiorly, consider epidermoid cyst. If it is anteriorly displaced, megacystoma magna, arachnoid cyst can be considered. Posteriorly, if it is displaced, isolated fourth ventricle and epidermoid cyst can be considered. In the megacystoma magna arachnoid cyst, the tegmentovermin angle is less than 18 degrees. In Blake's pouch, it is more than 30 degrees. In Dandy Walker malformation, the angle is around 40 to 45 degrees. Thank you.